Buongiorno. Buongiorno. You must learn.
I try.
You must try.
I have enough trouble in English. Let me tell you. So, we have quite a long list of subjects to go through, but I think it would be very nice if we could have a lot of discussion as we go through. Otherwise, I will give you 200 slides, and then you'll drown, and I'll drown, and everything. So, and if there are some subjects that you're not interested in so much, we could just move across them. If there are some subjects to spend more time on, of course. I'm not here to brand any product. I'm here as a scientist. I'm here as a toxin guy. But I have to use some of the data for some of the products to show you what's going on. Otherwise, I can't give you any information. So if you see any brands in there, I'm sorry, but it's just the way it has to be. When I can compare products, when there's a study to compare products, that's great. But sometimes there isn't.
Andy, it's perfectly okay because it's just between us.
Sure.
So this is science.
Yeah.
So that's,
But I get very sensitive about the brandings myself.
You know, the whole issue is with the guys from the press.
Yeah.
That's the whole issue. So they're out now, so you can just go ahead.
That's fine. So this is the agenda. It's a slightly different order than I had in the original piece of paper because it just made a lot more sense. So just looking at the position of toxin and what's going on, and particularly what product data are relevant and irrelevant. A little bit on how toxin works, not a lot, just a little bit there because of some information. The anatomical importance, pharmacology of toxin, which is quite a mystery to some, and then to other people they think if you just do an animal study on toxin, then you've solved the problem. To talk a little bit about the AEs that we see, and then I've got some slides on the future, a little bit more than I showed this morning, a little bit different as well. Okay. So here we've got the use in the States, and as I said to the press this morning, it's very difficult to get really good figures because this is just one society of America, one society, and one country. And if you look at different surveys from other countries, the so-called International Association of Aesthetic Plastic Surgeons, you get different numbers. It's very difficult to put them all together. But we think clearly that the States is just about 50% of the world. So we have this huge, really 10 million, 12 million patient treatment that's going on annually. Annually, that's not like in 10 years, that's every year now. We're seeing about 10 million patients treated aesthetically. And again, that's not therapeutically. And I don't think generally it's really appreciated how many patients are being treated every year aesthetically with that. In some countries, we will never get data. For example, Brazil, it's impossible to get data on how much is used aesthetically. And you know as well as I do that the vast majority, the majority by a long way, will be off-label use as well in countries like Brazil. We also have no idea at all, no idea about the age spread, the age range of patients being treated. I think it's likely that girls as young as 18 are being treated with toxin prophylactically in the face and even in the rear end. We know of a lot of cases where it's being used in the buttocks as well. And I think there's a lot of very old people being treated as well, 70, 80, maybe even older than. What we also don't know is what the split is between men and women. And I think that there is a big growing trend towards men getting toxin treatment as well. So that number, 10 million, 12 million plus, is probably 85% women. So if you add to that the upcoming growing number of men, I think is very, very interesting indeed. I've just put this slide in.
Can I ask you a question very quickly?
Of course, anytime.
If I remember correctly this morning, you said that probably the rough figure could be about 20 million per year.
Yes, total. Yes.
So that means that the ratio between aesthetic and therapeutic uses is about 1 to 1. Is that correct?
Yes. We work in figures, or my colleagues in different places work in figures, 50-50, 45-55 each way. It's around about that. Allergan's own numbers are around about that number as well.
Sorprendente. Sorprendente. Okay. Sorry.
No, that's not. So these are the standard type of aesthetic indications that are listed whenever you see a product. This is a Spaywood product. You can see we've got some recommendations, some quite detailed recommendations. And I see a problem that we have, and that is we're getting too many recommendations now. There are a lot of recommendations. There is often another set of recommendations, what to do, how to use it, where to go, what dose, and everything. So we have to be very careful, and we have to keep looking at those, because they change with time. As the years go by, those numbers change. Generally, there is a trend now towards lower doses aesthetically. And there are certainly some key opinion leaders in the States that say they have been reducing the dose in their patients year on year on year.
Is this only in the front?
This is all
areas?
the upper third, the upper third, yeah. But we've got also other recommendations as well, and you can see here all the other different areas that have been reported, the common areas there. Some of which people believe very strongly in, for example, the bunny lines, and some of which people have great trouble with, such as the nose tip. There are many clinicians who say that doesn't work. And there are others that say I can get a 0.5 millimetre or 1 millimetre improvement in the nose. So I think it's very much depends on the individual practice and the, if you like, the experience of a particular clinician, how well it works and if it works at all. So these are like the second group of indications. And then we've got a new set of indications coming out in the aesthetic world. We've got people who are trying to see whether it can be used in, let's say, different ways. And this from Cohn de Boule, just published very recently, is a very interesting piece of work because he's actually using toxin a bit like filler. He's decided that he can treat these so-called sleeping lines, particularly on men, that appear. And he is deeply opposed to the reason why those sleeping lines appear. Normally, the sort of theory is that it happens when you put your head on the pillow at night. He is completely against that. He says, no, it's to do with the musculature, it's to do with the skin quality, it's to do with those things. It's got nothing to do with sleeping at all. And you can see he got quite a good result with this person here. And again, slowly but surely, we're seeing toxin being used quite like a filler, and actually the two are being used together. So it's quite common practice that I see now for clinicians to do it in the same session. Sometimes they left it sessions apart, a couple of weeks apart, but I actually see the data now that they're doing it in the same session. We've also got another publication from him. He's been quite active recently, looking at the nasal columella area. And you can see here, this is the area he's focusing on. And he's seeing small improvements by just giving toxin in different ways there. So again, this is a brand new use of the toxin in areas that we never would have thought about before, which I think we have to keep very careful watch on what's going on. This is only toxin. There's no filler involved here at all. As I said this morning, as far as we're concerned, the safety of the patients is the most important. It's something that I feel very strongly about. It's really the biggest issue. You can deal with poor efficacy, but you can't deal with poor safety. Poor efficacy you can do something about later on, but something happens safety-wise to the patient, that's a problem. And so we're really into quality, we're really into the regulation side of things. Now some people want toxins regulated more, because in some countries, of course, nurses inject toxin, and quite a lot of nurses inject toxin, particularly, say, in the UK. And that seems to work well. there doesn't seem to be any issue because the nurses are actually highly trained, and the medical system in the UK gives them the ability in certain cases to prescribe medicines, the nurses can. So it works. There's no big safety issues in the UK. I can't say that about other countries though, where nurses are injecting, and probably illegally in some places. We've got a lot of product data. It's very regulated, it's very controlled, it is very standardised. I don't think it's generally realised that even the vile the words on the label and the colour of the cap, they're all regulated. There's no doubt about it at all, but the regulators have to approve every single aspect of the product vials and product boxes before they're released. So let's have a look at some data, some product data. And again, like with consensus papers, there is always another review on toxin in glabellar lines. Always. Last year it was one a month. One a month is impossible to deal with. Impossible. We don't need one a month on product data. And we have papers like this that are published. So this, I think, is from last year. We've got a table of data here with all this stuff, all this information on it there about the products. And actually, all of those are wrong. They're wrong. They're actual errors. They shouldn't be on there. The data for this is non-existent. This is wrong. Some of these ways it's prepared. Storage temperatures are wrong. And some of the comments that are made are wrong. They're wrong. Here's another one, actually from a very respectable clinician, Nick Lowe, very respectable. And he published another review. And here is his table. And here are his errors. These are all errors that Nick Lowe has made in the data there. I mean, there's saying, for example, that some of these products are not approved for hyperhidrosis is wrong. Some of these other the other places are wrong for some of these conditions as well. And again, these data are wrong. So again, we have another set of data that's wrong. And we have here the latest data, the latest table. And this was meant to be a summary of one product and its use in glabellar lines. But to make the paper bigger, and I am going to be quite hard about this, to make the paper bigger, you put a table of data in with all the other products in there. So here's another table of data. And on this table of data, all of those things are wrong that I've taken out. So we have a real problem that we have lots and lots of data on these products that is actually not relevant and is generally wrong when it's published. I think that's a real issue. I think that's an issue for the journals. I think that's an issue for the reviewers, because we should never get to the position where a table of data on products is wrong. We tried some years ago, my colleague Karen Perrow and I tried some years ago to publish the exact data, and then everybody could use that as a reference. And we failed miserably. We've totally failed. People don't refer to it. They just do another table of data, because it's the way you get it into papers.
Where do they fish out these information from if they're wrong?
Well, sometimes we don't.
From the previous paper? Or whatever?
Yes, sometimes. Sometimes we don't know because they don't reference any of it. Some of those previous tables have no references on at all. Here, there's a lot of references, but actually the data in the table and the reference are wrong anyway. So they don't do the obvious thing. There's only two places to get the data from, just two. Number one is the pack insert, the SPC, and number two is the manufacturers. They only have to make a phone call and check. And we've tried so hard to get people to do this, to check the data that they publish, but they don't do it.
It's interesting because these reviews and the works that that these reviews treat are published by index journals. And so, what's the job of the reviewers?
It's even more interesting because this publication is sponsored by Mertz.
Yeah.
This is a Mertz publication, and even Mertz can't get the data on there right. So, I think the issue is with the journals. I think it is with the reviewers, and I just don't think reviewers review properly some of this stuff that's going on. And this situation we need to realise is getting worse in the aesthetic world, not better. Getting worse. Because now, of course, people will refer to these publications as information, and so you end up with this sort of snowball effect. I've used this set of data for a long time now, because I think that probably only 2 columns of data are relevant to you, to practicing clinicians. And one is about potency and one is about formulation. And formulation, just so that everybody knows, they're different formulations for the products, between the product families. And the units are different. I think it's totally irrelevant to you to worry or even think about the pH of the reconstituted product. You would expect it to meet the specifications. I think it's crazy to worry about all this temperatures of storage, because you know it's printed on the box what temperature you store it at. So and sometimes we see data that says you can store a product for 3 years at room temperature. Do any of you store your product for 3 years? Do you keep toxin for 3 years? I doubt it. People are driving it as a quality thing. It's not a quality thing at all. I doubt whether there's a clinician in Europe that stores his product for 3 years in the fridge. Because it's an asset. That product is your asset. You want to use it. You want it to go through into patients. We've got these interesting names here, which came about in 2009. They were given to us by the US FDA, and they said that we do not believe that the name Dysport or the name Botox is different enough from each other. We don't agree. We think all the doctors are going to get confused. So we want to name the products with something which we think the doctors will understand. And so they gave us this part, botulinum toxin A, and they said to us, you choose the first 3 or 4 letters that go on the front. And we did. We chose some different letters, and they said, no, we don't like it, choose some more. And so we chose this. Has no meaning whatsoever. Has no meaning at all. No, not one. Has no meaning at all.
We'll still asking for.
There's no meaning to this at all. This is this, this is this, this is this. They're the same. There's no meaning there whatsoever. And then FDA were happy. And that's why you see these names now appearing in publications, but they have no relevance for anything other than the United States. They're not relevant for Europe at all. They have no meaning in Europe, but we still see publications coming out with these names on. What is important? The dose I'll talk about a bit later, the number of injection points, we'll look at some clinical data for a little bit later. So are these important? But actually these two go together. These two are completely linked. Because if you want to get the right number of units in, you have to change both of those. What you have to focus on is getting the right number of units in. So the question is the volume that you put in there with the units important? And the answer is, it might be. Because there are studies that show it isn't, and there are studies that show it is. This is the study from Carruthers on Botox. Good study. 20 patients a group, 4 different dilutions, in other words, 4 different injection volumes to get the same number of units in there. And he shows no difference. This is always, my graphs are always maximum response, maximum frown in that case. He shows no difference between the dose groups. But then you look at his injection points, and I would suggest they're quite different to what most people would do now, because he's got an extra injection point here and here for his work. But he showed no difference there at all. Here's a study where there was a difference. This is a small study by Abbasi in the States. And he had a split face study here, and he was looking at forehead, not glabella, but forehead wrinkles, and he showed that he got more reduction when he put more volume in the forehead. There's been no single piece of work to look at volume of injection in modern times, because the Carruthers thing was now 6 years ago. No modern study to see whether truly the volume has an effect. And I think that one is needed, and in fact we're planning to do one. It's time to now do a good study where people are taken and we do exactly varying the volume between 2 different ways of looking at it. It's very important to do that piece of work now, because the question comes up all the time: what dilution do I use? What dilution do I use? And what people really mean is, what volume do I inject to get? What is the effect there? But also what we do know clearly, without a shadow of doubt, is that there is a significant placebo response with toxin studies. Between 5 and 10% of patients injected with just placebo do respond. And they give a rather long response too. What we don't know is whether the needle, or whether it's the liquid, or whether it's the needle and the liquid. It's certainly not the toxin, because there's none there. So there is this placebo response, which is why the best clinical studies in the toxin world are always done against placebo. They're the best studies. But I think it is very interesting that there should be this placebo response. And of course that gets worse. It increases a great deal when you think about headache, migraine. The placebo response for migraine is 40 to 50% of patients, which makes migraine a very debatable subject. Should you give any toxin to patients if the difference is only a few percent? And that debate still continues today on migraine. Volume of injection, we know between the different products is different, can be different. We know that you can get the same effect with this product using a small volume. So the question then is, if you change the volume to this volume, same number of units but a bigger volume, do you get the same effect? And the answer is probably yes. For all we can determine, that change in the volume is not important. But there is something else to do with volume of injection, which I think needs again further investigation, and that is pain. So this is a pain study. It's not the sort of study which we can use to say definitely, but we can use it as a guide. It's intradermal toxin, different doses and dilutions, and you can see here that on a pain scale, there was less pain with a smaller volume, less pain with a smaller volume. But there are other reasons why patients would experience pain on injection, and it's not related to the product, it's actually related to the needle. And what is undoubtedly the case is that after the first injection, the needle gets blunt. After the second, it looks pretty bad. after 5 injections, it's a real mess. When you look at the end of a needle, the needle actually bends at the end. Even though it's made of stainless steel, it still bends. So it's not surprising that on the 5th injection, the patient might feel something quite significant compared to the first injection. So such studies are very, very difficult to do and to get right on pain there.
How do you explain the difference on the basis of injected volume? Is it the pressure on the tissues given by the extra volume that is actually getting in there?
Yes, I think it probably is. And I think also we don't fully appreciate how innervated the skin is and the layers of the skin, the dermal layers.
Because their speed of injection would also have
Yes.
a very big role as well. It's not only the needle or
Yes.
whatever.
If you look at an ultrasound of an arm muscle, say, that's being injected with toxin, and you watch what happens during the injection, you suddenly see this big bolus volume of fluid pushing all the muscles apart. So yes, I think pressure has a lot to do with it.
It's the same with fillers. I mean, it's even more
Yes.
so with fillers.
Yes, well, hence the lidocaine.
Yeah.
I'm not suggesting putting lidocaine in with toxin.
I do.
Do you?
Yeah, I've done so for years. I started doing that with about 3 or 4 of my patients who were particularly fussy. Every time they came in, it was a nightmare. So one day I just tried, and without telling them. And then I asked them if it was a better experience, and they all said yes.
Yeah.
So I've done it routinely since.
Do you put adrenaline in as well?
No.
Yeah, there's some people that put
I know.
adrenaline in as well. Low concentration adrenaline. And I've even found someone who puts vitamin C in as well at the same time. So,
Yeah, well, you can put any kind of broth in
Yeah,
there if
yeah,
you believe in it.
yeah.
Do you have an experience about diluting with water, not with saline?
I've probably got a slide on that later, but not with water.
Yeah.
Very painful.
Yeah, very.
Hugely
Very
painful.
I had once because it was a mistake and I diluted with water.
Yes.
This
It was,
was quite painful,
Yes.
but it worked.
Oh yes, I don't think there's any problem for the toxin. In fact, one of the solutions that toxin is quite happy in is water. But for the patient, because water for injection is very acidic, very acidic.
We carbonate.
I'm sorry?
We carbonate.
It's no more water.
I can't say about that because I'm only aware of one vague report of it, but not routinely. No one's ever reported it.
You know, this brings up another question for me. All of us have had the same patients for years,
Yes.
so we know them.
Yes.
We know if they're solid, if they're afraid, if they always complain, whatever. So imagine the patients that you know that are okay. They don't make fusses. But they tell you that each time the pain level is different. There are times it's absolutely okay, other times it's more painful. So I always thought it was individual variability on a day-to-day basis. But one day I found out, looking at the ampoules of saline, that the pH of saline is actually amazingly variable within the same brand. It goes from 4.5 to 7.2 pH, which accounts probably for this huge difference. So I have wondered, just as they said just now, if by buffering with sodium bicarbonate you could do anything good to it. Would that destabilize the toxin? Would that make any difference?
I think that would be difficult to say. I would have to do some work to look at that. To
You
check
don't know
that.
about that.
I would. I mean, that's quite a specific diluent to use. But I certainly agree about the saline, and the specification for saline for injection is very wide for pH. People don't realise, and I do suspect that different batches of saline have different pHs.
It's exactly like that because
Yeah.
I inquired with the people who make the actual stuff,
Yeah.
and they say it changes from batch to batch, and you can have a range from 4 point something to 7 points.
Yeah, we've actually just decided to do some measurements now on saline, because actually saline is not physiological. no matter what anybody says. It's not physiological solution. Saline was a sort of old historical thing from way back when that someone one day called physiological, but it's definitely not. So, because the pH range alone tells you that.